So, good evening and thanks to everyone for joining us today. We welcome you to the webinar today organized by Haryana chapter of ISPAT, and the technical partners for this webinar series is Jagsonpal Pharma, makers of Endorec, Divatron and Injection Mente. So we present to you Endorec micronized Dynogest 2 mg in endometriosis. We have Divatron 10 mg micronized tablets of dydrogesterone to improve compliance, and we have injection maintain 250 and 500 mg of 17 alpha hydroxyprogesterone to maintain positive pregnancy outcome. So warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. So to refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insight. Now we invite Dr. Jyoti Malik, Secretary Haryana ISPAT and Director Routes of IVF at JJ Institute of Medical Services, Bhatt, to kindly initiate the program.
Thank you so much. Thank you, Nimisha. Thank you, Jagsonpal. And welcome each one on board. This is Haryana ISPAT chapter launching its first webinar of Fetus as a Surrogate Patient. And before we go on to the webinar, we have our chief guest, Dr. Milind Shah, who is the National President of ISPAT. And for Haryana ISPAT, we have none other than President Dr. Ragini Agrawal, ma'am. So Dr. Ragini has her complete team of Haryana ISPAT office bearers. I will first go through that before I read Dr. Ragini ma'am's CV, so that all who have joined know that Haryana ISPAT has come up with a very strong and a very focused team, and we wish to do a lot of work on this platform. So we have our team, as told, Dr. Ragini Agarwal is our president for Haryana ISPAT chapter. Dr. Neeru Thakral is president-elect. Dr. Punita Hasija, Vice President, Dr. Divya Mangla, another Vice President, Dr. Moni Bhatia, Dr. Rachna Gupta, and Dr. Madanjeet Pasricha as Joint Secretaries, Dr. Shreyasi and Dr. Molshri as Clinical Secretaries, Dr. Punita Arora and as Treasurer, Dr. Reema Goyal as Joint Treasurer. And our founder president has been Dr. Maninder Ahuja from Faridabad, and our advisors are Dr. Manju Puri, Dr. Mala Arora, and Dr. Savita Singhal. We have executives and officials, Dr. Avantika, Dr. Gurneesh, Dr. Punita, Dr. Krishka, Dr. Kalyani Swami, Dr. Harsha Shekhawat, Dr. Rakhee Malhotra, Dr. Aarti Chitkara, and Dr. Shavika Kalra and Dr. Anu Sidana, along with Dr. Manisha Kadyan, Dr. Pooja Bhayana, Dr. Sarita Gulati, Dr. Aditya Garg, Dr. Dr. Rachika and Dr. Kunika. So these are the office bearers and the office executives of our Haryana ISPAT chapter. And we have a strong and a very guiding force, Dr. Ragini Agarwal, ma'am. And now I would like to have ma'am's CV, please. Dr. Ragini, ma'am, is a visionary. She is a leader, and she is a person who is a guiding force in Haryana. And recently, she also has been elected as the president of the National for the North India Gynae Forum, that is NIGF. So many hearty congratulations, ma'am, for another feather in your cap. Ma'am is also the Secretary General of IMS 2025. She is founder, chair, aesthetic committee.
Thank you.
And so many things we can read on this busy slide of CV of Dr. Ragini, ma'am. She is director of the Dharma Science, and she has. I will give it over to Dr. Ragini to give her blessings. And Dr. Milind Shah also, sir, has joined, but I think we'll take Dr. Ragini's blessings and then we go to the national president then.
Absolutely.
Thank you so much, Jyoti, for your always nice word. And I really congratulate. Welcome, Milind. Welcome to Haryana. I
Thank you, Ragini.
congratulate you and Neeru, who has taken this task to revive the ISPAT after 7 years for a very important, I can say it's a very important uh, to know about the fetus pre-genetics today's world, because no obstetrics is complete until unless you understand. And what a topic you have chosen, fetus as a surrogate. Really double congratulations. And I welcome you all on this platform as a president, Haryana ISPAT. And I'm seeing Bela Bhatt is also there. So I'm very sure you all are going to get benefited, because we obstetrician always has double responsibility on our head. And fetus is someone we are really writing her janam patri inside the womb, and every woman should understand what she will eat, what she will think, the type of baby she is going to deliver. And this message should go from us also to the patient when they come, doctor हम तो आपके पास आते थे मेरे बच्चे को ऐसा क्यों हुआ. So it's not doctor, it's themselves also. They can have a changes of epigenetic changes in their babies. So I will not stand in between you and the academics. Thank you so much, Jyoti, and I wish you and Neeru very best for taking this Haryana chapter as part to a new height. Thank you so much. Thank you.
Ma'am. Thank you for your blessings. And we always, you are our leader and we'll follow your vision. And your guidance is a must for Haryana as such, not only in ISPAT, but elsewhere, everywhere actually. So going on to our, can I have CV of Dr. Milind sir? Dr. Milind sir is our national president of ISPAT, and sir is has been the president of ISOPAP, has been a member of the Maternal Fetal Medicine Committee of AFOG. He has been president of IMA Solapur branch. He has been chairman of the Safe Motherhood Committee of the IMA Maharashtra state, and been a founder president of IHRF, the Infertility and High Risk Foundation. He has been the vice president of FOGSI in 2011, and also the deputy secretary general of INSARG. He also, I think it is a very long CV, and I think Professor Dr. Milind Shah sir, not only he is a thorough academician, but he's a thorough gentleman, and I think a person who is readily approachable and knows his subject. So he is now presently, he has taken over as the national president of ISPAT, and with his support actually we could revive the Haryana chapter. So thank you so much, sir, for giving us that courage and for giving us that holding our hand, so that we could again grow as a chapter which was forgotten for some years. So over to you, sir, for your blessing, your words of wisdom.
Yeah, thank you very much, Dr. Jyoti, for all those kind words. But in fact, I must owe a lot to you people, because you made such a vibrant chapter. And fortunately, I was there for your perinatology conclave, which was one of its own kind. And definitely it's creditable to all of you, as it is the big leader, Ragini. I'm not saying big only because of her size, because she has proved herself to be very great actually in her endeavor of starting and rejuvenating this ISPAT chapter. And Dr. Jyoti Malik, Dr. Neeru Thakral, Dr. Saroj Singh, and so many of you. And then when I got this invitation of a fetus as a surrogate patient, Jyoti, let me congratulate you, because we are conducting the webinar series on fetus as a patient. which is absolutely not correct because at present, the fetus is not having the rights of the patient. It's a surrogate patient. So putting that surrogate word, you have made it really absolutely practical thing, which we must convey to all our delegates who are viewing this particular wonderful webinar done by you and Dr. Moni Bhatia. In fact, you read all those names. I wanted to read that because they're so close friends of mine now since so many actually days. And it was so incidental that God also brought me there for even the cultural eve which we celebrated last Friday. It was so incidental that I was traveling to the many of the societies of Bihar, and only Friday was vacant. So I came from Darbhanga to Gurgaon just to attend your wonderful evening, the enthusiasm, and I wanted to see that. Now, coming to the today's topics, yes, this is very, very important to understand the tricks for the obstetricians on the case-based scenario on Bela. Bela is absolutely a good friend. She had proved her committee work. She presented her work in even our genetic screening in the webinar. And I realized that yes, that is what the clinicians they need to understand. Another challenge which we face is the yes, the IUGR, which again we need to definitely work a lot to make a successful change. And I'm very sure you and Moni Bhatia will definitely make it's very lively under expert actually guidance of Seema Thakur as well. And I'm sure that all those panelists, the Divya Agrawal, Gaurav Java, Savita Singhal ma'am, Divya Mangala, as well as the Rachana Gupta are going to put good inputs for the all those intricacies of managing intrauterine growth retardation, what we call the FGR nowadays, which is again very important the input we need to have in our day-to-day work when the baby comes. What Ragini said is very true. Patient always say, अरे हमको आपको दिखा रहे थे फिर क्यों हमारा बच्चा एकदम छोटा हो गया. So all that we need to understand, we need to have a counseling tips as well, what exactly we can do. And I'm very sure this coming discussion is going to put a good input and good messages for all those viewers. Let me congratulate the entire group of ISPAT Haryana. I'm looking forward in coming 2 years to do more and more wonderful work as well as research, which is again an integral part of that. In fact, friends, it was so incidental that today evening I'm traveling to Colombo, Sri Lanka, to speak in the perinatology conclave where we are going to come out with some draft consensus, and probably I will now involve you all in those activities once we create that draft about the certain discussion about the reducing perinatal mortality and morbidity. So let me complete that and come to you with some ideas and research on that. Thank you very much for inviting me. It's indeed an honor, rather more a pleasure to join you for this webinar. Thank you, Jyoti.
Thank you, sir. Thank you so much. Thank you. Looking forward to working under your guidance and learning more from people like you. Thank you for joining, sir. I understand you were on your way to Colombo and still you could join us. Thank you so much. Moving on, I would again like to thank the co-convener and moderator for today, Dr. Moni Bhatia, who took pains to curate this program. And we now move on to the clinical part, and we have a wonderful speaker from Mumbai. And before that, I would like to invite my chairpersons, Dr. Neeru Thakral, the president-elect, Dr. Meenakshi Chauhan, Dr. Rakhee Malhotra. So, Dr. Rakhee is Director RAS Fertility, Vice Chair Haryana Chapter ISAR, and Joint Secretary Harokain. Dr. Meenakshi is a senior professor and unit head Pandit B.D. Sharma PGIMS Rohtak with experience of 34 years and a master trainer for emergency obstetric cares, has a number of awards to her credit, more than 100 publications, authored many books. And Dr. Neeru is,
thank you.
all know, she has been the Director Morpheus Thakral IVF, Vice President Haryana Endoscopy, Past Secretary IFS Haryana chapter and the Clinical Secretary Haryana AG, and now the President-elect for Haryana ISPAT. So I would request Dr. Rakhee to please invite our speaker, Dr. Bela Bhatt. Can we have her CV? So that, and her topic would be Gene Tricks for Obstetrician, a case-based discussion.
Thank you, Jyoti.
Uh,
Thanks a lot.
uh, First of all, congratulations to Dr. Ragini, to Jyoti, Dr. Milind for part to a great new height and giving me the honor to introduce Dr. Bela Bhatt. And everybody must be knowing her already for her nice dances we see in every conferences. She's so energetic. She's the chairperson of FOGSI Imaging Science Committee, and she has certified serologist for fetal abnormalities and nuchal scan. She's the author of the book The Vital Skill, the Ultrasound in Obstetrics and Gynecology. She's a FOGSI recognized trainer for ultrasonography in Obs and Gynae and secretary in Mumbai and MC member of ISPAT. So she has so many awards as we can see on the screen to her. And I welcome you, Dr. Bela, for your talk.
So thank you so much, Dr. Rakhee, for those very kind words of introduction. And at the outset, let me tell you, it's indeed pleasure for me to be the part of this kind of revival webinar for Haryana chapter of ISPAT. And I'm extremely thankful to dear friend and one of the convener, Dr. Jyoti Malik, for giving me opportunity to be a part of it. And of course, the convener, Dr. Moni Bhatia. And what to say about Dr. Milind Shah, sir, the president ISPAT. I mean, we have been connected since so many years in FOGSI and ISPAT, and we have worked together in so many FOGSI conferences also. And sir has been such a guiding force and inspiring person that we always love to work under leadership of Dr. Milind Shah, sir. So indeed a pleasure and honor to be on this platform and talking here. And Dr. Ragini Agrawal, madam, or the guest of honor for today. Again, a person who's really we all look up to, and always guiding and supporting in all good activities, academic activities. And I'm also thankful to all the office bearers of Haryana chapter of ISPAT. I'm sure it's going to do very well in future as well. So without much ado, I'll just share my presentation. Hope it is visible to all.
Best wishes, Dr. Bela, Dr.
Thank you.
Milind, everyone from Haryana chapter of
Thank
ISPAT.
you so much,
We
Dr.
all are
Neeru.
with you.
So nice of you. Thank you very much.
Thank you.
Thank you.
Yes. So, before I start, I would also like to wish the best wishes to Dr. Milind Shah, sir. And
Same to you, Dr. Bela. I'm
thank
very
you.
sure.
Best wishes, Dr. Milind.
Definitely.
Dr. Meenakshi this side. Best wishes.
Yes, Dr. Meenakshi. So nice to see you again. Great.
Nice. Yeah,
Thank
yeah.
you. So the topic given to me is gene tricks for obstetrician. Now, why did I select this topic? Because as it has been already discussed before, nowadays the obstetric practice is not separate from genetics. We all know obstetrics, fetal medicine, ultrasound, genetics are all, hand in hand. They go hand in hand. And for every patient, right from early pregnancy till delivery, we depend on ultrasound and also on genetics and geneticists, because we know there are initially we just used to do the anomaly scan in second trimester anomaly scan. Now we have moved on to the first trimester anomaly scan as well. And with the advent, as the ultrasound field is evolving, at the same pace, genetics is also evolving. And therefore, ISPAT has become very, very important, because without knowing about genetics, no obstetrician can practice even in their routine obstetric practice. So, what I'm going to talk about today is something which is very relevant for every obstetrician in day-to-day practice. Right? Now, we all are doing screening for aneuploidies. whether it's a first trimester screening with nuchal scan double marker or the second trimester screening with quad marker or genetic sonogram. We are all doing screening. Now, we know that the basis of it is to try and find out some of the common chromosomal problems, right? And we also deal with so many single gene disorders, thalassemia, sickle cell, whatnot. So I'm just going to give, first of all, the basics of understanding these chromosomes and quickly go to some of the case discussions through which we can learn. So we all know a cell is a euploid cell when there is a complete chromosome set of either 46XX or 46XY. But when there is any change in either chromosome or genes, it leads to genetic disorder. But from suspicion till diagnosis of genetic problem or genetic disorder, it's not so simple. It's a very, very complex issue. And that's what we all have experienced in our daily practice. So I'll just touch upon the common genetic problems. Now, what are the common genetic problems? Number one, aneuploidy, which is abnormal number of chromosomes in a cell and addition of one chromosome. The commonest example, trisomy, deletion is monosomy. And for common trisomies, we know it's trisomy 21, 18, 13. Whereas for common monosome, it is XO or Turner syndrome, which is monosomy, right? Now, triploidy is when there is absolute extra set of chromosomes from either of the parents, and try and find out the possibility or the risk of these common chromosomal problems, we have some of the screening tests, some of the diagnostic tests. And which are the screening tests? The combined test as first trimester, which is nuchal scan plus double marker, NIPS or NIPT, quad marker, integrated test, and genetic sonogram. Again, I'm not going to go into details of it. We are using all these markers, the CRL, the NTNB image, the DB, TR, and we look at the various biochemistry also. But with the help of all these screening tests, what are we doing actually? We are segregating low-risk population from the high-risk population. And this high-risk population is then offered diagnostic tests through CVS or amniocentesis, and then we try and reach to the final diagnosis. But friends, we all know things are not so simple and it's very, very complex. So what are the diagnostic tests after we perform the CVS or amniocentesis? Well, we all know we have FISH or QF-PCR, karyotype, microarray, and whole exome sequencing. Now, obviously, we would first like to know as to what are these different tests. So this is nothing but zooming in on a chromosome through this diagnostic test. So what do we do when we look at the karyotype? Well, we'll be able to find out defects which is of the size of 5 to 10 megabases. But when we zoom in further on the chromosome, we'll be also able to see some of the micro deletion and duplication. So we'll get information to the tune of 50 to 100 kb. But in whole exome sequencing, we'll come to know about single gene disorder. So that's the beauty of going from karyotype to microarray to whole exome sequencing, depending upon the suspicion of a condition. Now, the benefit of microarray is it detects 6 to 7% of more clinically relevant abnormalities as compared to karyotype, whereas whole exome sequencing will pick up single gene defects which are not picked up by microarray. Now, we know once we do the first trimester screening, suppose we have done the combined test, that is nuchal scan and double marker, and the result has come positive. That means if it shows that there is high risk for trisomy, either 21, 18, 13, maybe 1 in 150, 1 in 100, 1 in 50, then what do we offer to this patient? Yes, we tell the patient, you need to go for the CVS or amniocentesis, but the tissue that we get, what test are you going to offer? So remember, in any screening test, we always step up. So the first test that we can do or offer is a quick aneuploidy test like FISH or QF-PCR, because it would give us the result within 2 to 3 working days. And if you find that it is abnormal report, maybe trisomy 21, 18, 13, then you can offer karyotype and know the type of trisomy. But if the karyotype does not show any abnormality, then you can offer microarray. And even if the microarray cannot pick up the abnormality, then we offer the whole exome sequencing. So this is the logic behind stepping up in the screening and then diagnostic tests. Now, the options that we have to offer on the sample of CVS or MNO is first or QFPCR followed by KT or microarray, or these days many centers directly offer microarray. But remember, whenever you offer microarray or whole exome sequencing, maternal blood has to be sent in ADTA for maternal cell contamination. And needless to say, pre and post test counseling is extremely important because this is very complex issue. Patient may spend so much 30,000, 40,000 on whole exome sequencing, and sometimes the result is not there. At the end of the test, we may not be able to pick up any single gene disorder, or at the end of microarray, we may not be able to pick up any microdeletion or duplication. So pre and post test counseling both is extremely important, which has to be by both the obstetrician, fetal medicine specialist, and geneticists. Now going on to the cases, this is a case in which there was high nuchal translucency at nuchal scan. As you can see, it was 7.8 millimeters, and therefore it was very high. Patient was offered CVS first, but there was also some generalized subcutaneous edema and very high nuchal translucency. Patient didn't want to continue. They terminated the fetus. But it's very important that even if you terminate the fetus, that fetal tissue or the product of conception should be sent for genetic testing. In this particular case, also it was sent for genetic testing, and it turned out to be trisomy 21. So it's very important to try and find out the cause, number one, because once you know that there is some kind of genetic problem, then we will be able to help the patient regarding counseling for next pregnancy. What if it is not a common chromosomal problem, but some autosomal recessive or autosomal dominant condition which has been picked up? Then there'll be 25 to 50% chance in every pregnancy to get that genetic mutation. So in which case, in next pregnancy, we'll have to do CVS, rule out that defect, and then help patient. So that's the reason why we must offer the genetic testing even once you terminate the baby, and product of conception should be sent for genetic testing to genetic lab. Now, in this particular case, trisomy 21 was diagnosed. So now the patient wanted the next pregnancy. So the first question was, is it going to recur in next pregnancy? Now, how do I know? Well, depending upon the type of trisomy, the recurrence rate is different. In 95% case, it is a free trisomy, in which case the recurrence is just 1% above the age risk. But in 4%, there can be translocation type of trisomy, out of which 1% is familial, where the recurrence is very high. If the mother is a carrier of 2114 translocation, 12% chance of recurrence in next pregnancy. If the father is carrier, 3% chance of recurrence in next pregnancy. And if it is 2121 translocation, there is 100% chance of recurrence. So unless and until you have done all this in this pregnancy, you will not be able to counsel the patient. So that's the reason why you must try and find out and counsel. Now, this particular patient who had this Down syndrome in this pregnancy, conceived next time, came to me, and she had free trisomy, so risk was not very high, but she wanted to be 100% sure in next pregnancy that there is no Down syndrome. So I did CVS, chorion villus sampling, which was normal, and then she continued and delivered baby with me. Whereas another patient who had Down syndrome in next pregnancy was offered all the tests, the highest sensitive screening test for Down syndrome, that is new NIPT, and the patient preferred that over the invasive test. NIPT came low risk, and she continued and delivered a normal baby. So it all depends on patient's choice as to what test it wants. But if there is previous Downs baby, we must know the type of trisomy and counsel the patient regarding next pregnancy and testing. Now, that was about common trisomies. Now, we also have so many single gene disorders which are common in India, like beta thalassemia, sickle cell disease. We all know is very common in India. And these are autosomal. There are various genetic mutation which can be autosomal recessive, dominant, X-linked. Now, the workup in case of single gene disorder is very different from that in aneuploidies. So it's very important to understand how should we work up this patient step by step. So step 1 is, in cases of beta thalassemia, there are two types of diagnosis. That is first thing to understand. One is laboratory diagnosis, which is based on HPLC, which will just tell you that a particular person is affected by thalassemia minor or trait, who is a carrier. But once somebody is diagnosed with thalassemia minor, it's important to do the genetic test to try and find out what is the genetic mutation, because then only we'll be able to work up. And now we know that once we find that the mother is affected by thalassemia minor, the husband also has to be tested for HPLC. And if both the husband and wife are carriers, then only the chances are there that it will be inherited to the baby. And this being autosomal recessive condition, 25% chance of the fetus having thalassemia major is there. So now what is the next step? Next step is to try and find out the type of mutation in parents. So, and then do the CVS or amniocentesis to find out the same mutation in the fetus, whether the fetus is affected by thalassemia major or not. So this particular patient came at 6 weeks to me with the diagnosis of thalassemia minor in hand. But that's just a lab diagnosis. We can't wait till 3 months and do CVS. What do I test it for? So what I did, both the parents were having thalassemia minor. So their genetic testing was done, which did show the gene mutation. Now, what is very important is HPLC has to be a part of routine ANC profile, because thalassemia minor is a very, very common condition, and thalassemia major, if it occurs in the baby, is a very, very severe condition that affects the baby. So once the mutation was found in both the parents, I did the CVS at 12 weeks and looked for the same mutation in the fetus. Fortunately, this fetus was not affected by the mutation which the parents were carrying, and therefore they continued the pregnancy, and the baby was normal, is now 6 years old. Another genetic condition, which is the couple presented at 7 weeks of pregnancy with consanguineous marriage, previous baby with biochemical diagnosis of galactosemia. Now, her first male child was affected by galactosemia and became very, had a lot of complication after birth, because they took 1 month to diagnose this single gene disorder in that first baby. And therefore, in this pregnancy, they were very cautious that I do not want the same complication in this particular baby. So at 7 weeks, when they came, the again, the lab diagnosis of galactosemia was done, but there was no genetic diagnosis. So I send the index child blood to the genetic lab to find the mutation first. That's a step 1. And the index child did show this genetic mutation for galactosemia in homozygous condition, which was pathogenic for galactosemia. Now, both parents were tested. That was a consanguineous marriage, and both parents were found to be having the same mutation, so they were carrier. So at 12 weeks, I did CVS and tested for the same mutation, and this time the report showed that the baby was a carrier, heterozygous, carrier of the same mutation, but was not homozygous, so was not affected. It was carrier like parents, so they continued the pregnancy and delivered at term a healthy girl baby. Now again, after next pregnancy also, they wanted to continue. So again, we did the CVS at 12 weeks. Now this time, the baby was completely normal, not even carrier. They continued and delivered at term. So this is the beauty of finding the mutation and helping the patient in every pregnancy, because if any time it shows that it is thalassemia major, they have option to terminate, because we know thalassemia major is a severe disease where every month blood transfusion is required till the baby survives 15, 20, 25 years. So learning points in this is step-by-step testing is important in all these single gene disorders, and it takes time. Preferably, these tests should be done pre-conception, not even early pregnancy. They should do it before conceiving, so that in next pregnancy, we can do CVS and try and find out whether the fetus is affected or not. Now, this is a very, very interesting case in which the couple came for preconception counseling for removal of copper T. Now, she was gravida 3, para 3, all full-term normal deliveries, one son, 2 daughters, but out of the 3, one son and 1 daughter were deaf. 1 daughter was normal, but 2 of them were deaf. It was a non-consanguineous marriage. So they came for preconception counseling saying that, doctor, can we check that something so that my next child is not deaf? Now we know there are genetic causes for deafness. And there was something very striking in the maternal features. She had brown colored iris, unusual wide nasal bridge, wide forelock. Her hair she had a white forelock right from birth, but she had normal hearing and normal IQ. The husband was absolutely normal. The elder son, 12 years old, had the hearing loss, both gray iris, and also had white forelock since birth. So these were the common features in mother, the deaf son, and the daughter who's 7 years old also had right from birth. This is the photo of birth, white forelock, as you can see, one gray, one brown iris, white forelock, and unusually wide nasal bridge. So with all these phenotype, geneticist was counseled and geneticist said that there is a possibility of a genetic condition known as Waardenburg syndrome in which there can be genetic cause of deafness. So we need to do genetic testing. So first of all, the more affected daughter's blood was sent to genetic lab and it did show the mutation for Waardenburg syndrome, which was pathological, and it's an autosomal dominant condition. So now we know that it was inherited from the mother to these 2 babies, right? And then step 2, mother's blood was then sent for the mutation to find out, and the mother was also having the same genetic mutation that was Waardenburg syndrome. Now, after having understood about this, patient was counseled that this is autosomal dominant. So in every pregnancy, there's 50% chance that baby is affected by this, and there can be variable deafness. Like mother was not deaf, but one son was severely deaf, girl was severely deaf, and the son was mildly deaf. So there is a chance of deafness in 50% and 50% chance that child will be absolutely normal. So either in next pregnancy, we can do CVS to find out for this mutation, or they have to go for donor ovum IVF so that this doesn't come into picture. But copper T was removed. They wanted CVS at 12 weeks, which was performed, and the fetus this time was not affected by Waardenburg because the mutation was not found. They continued the pregnancy, delivered with me, this female child. There was no white forelock that was to begin with. Now the baby is 4 years old. Hearing is normal and not affected by Waardenburg syndrome. So I think this is the beauty of working up on a case, finding out the genetic mutation and help them in, time find out whether the baby will be affected by not or not. But remember, all these tests that we do for genetic mutation take almost 6 to 10 weeks. It took 10 weeks for both the reports to come. First, the daughter and the mother and all took 10 weeks. So ideally, it has to be done pre-conception. If you do it in pregnancy, then you lose the golden time. And maybe by the time the reports are in hand, it will be 24 weeks. So in this case, because I had the mutation before the planned pregnancy, before I removed the copper T, it held the patient in next pregnancy. So it's very, very important to find out that. Now, in this case, we could find out the mutation. But remember, genetics, always the answers are not available. And many a times we work up. I have many cases, but I'm not putting here for the want of time. But remember, I have also had the cases where we did the whole exome sequencing also, but the genetic mutation we couldn't find. And therefore, there are missing links in genetics. That's the reason genetics is evolving every day. What is there today will definitely have better taste after 1 year, 2 years, 5 years, and we'll know many more genetic disorders in future. The reason being, as far as the story of exome and genome is concerned, we are looking at the exome, which is just 1% of the whole or the entire genome. Genome is intergene area, which we are not testing right now because all genetic material is in exome. But then what we are looking at is just tip of iceberg. We know just about 0.2% of genetic disorder. There is so much scope to know more and more, to research more and more in this area and try and find out more and more genetic disorder so that we can find out the cause, find out the mutation, help the patient in next pregnancy, do CVS, rule out in the fetus, or if it is there, counsel the patient. And if they do not want to continue, they have the option of termination. But at least if they want to continue, they have the knowledge that this is what the baby is going to be affected by. So remember, DNA is a mystery which is yet to be solved, and I'm sure we'll continue try and solving this mystery. And with this, I'll conclude my talk. I once again humbly request you all to support me for my candidature as the Vice President FOGSI. And the election is from 1st to 10th August. It's an online election. Just take out your 1 minute and do support for my Vice President from West Zone. Thank you so much for patient hearing. Thank you.
Thank you, Dr.
Doc-
Bela. Thank you for the comprehensive knowledge to everyone about genes and genomics. It's
Thank
very, very essential and very nicely curated whole talk with the very interesting cases. Thank you. So we can very well go for preconception counseling, or we can do IVF with either donor oocyte or with the PGTM, single gene defect. With the PGTM, we can check which embryo is affected and which not. So we can transfer the not diseased embryos.
Very
Thank you very much.
Thank you, Dr. Bela. Very crisp detail you have told, and all those cases. And the advantage of these tests are that many times when one child is affected, many couples they are afraid. They won't even try another pregnancy. So with this, at least we can test and we can give them a good outcome many times, as shown, as you have shown in many of your cases, that the fourth child was normal and they were very happy. So it is an era of fetal medicine, definitely. So perinatal medicine is coming up, and it's really very helpful. And everyone should be aware of all those screening tests. And they should also know about the precautions and everything in taking sample while doing the first trimester scan, the screening tests. That sampling has to be done for dual marker at the same time when we do ultrasound, because especially like in our places, we are getting patients from rural background. They will just get the ultrasound done and they will get the dual marker maybe after 2 days, 3 days. So that awareness has to be spread. I mean, it is now become essential to screening for thalassemia, screening for this first trimester screening. They have become almost essential, and it should be liberalized by the government also. Actually, I should say that in government institutes, these things should be made free of cost. So we would also like to work in this.
I'll just make one comment here regarding the nuchal scan and double marker that we just talked about. Because the thing is, for double marker, why they ask for the ultrasound report is they want precise dating. So if scan has been done 2 days back, we can always attach the copy of that report with the double marker form, and they'll calculate if it was 11 weeks, 2 days, then it is going to be 11 weeks, 4 days then when you send the
Yeah.
double marker.
Yeah.
So it's okay. It's for dating purpose. Only thing, the report which is there in their hand should have been done in a standard manner. If it is not, the CRL has not been taken in a proper manner, we should look at the images. If the CRL has not been taken in a proper manner, then yes, we must do a proper nuchal scan in a standard manner and then only send the sample. But if it has been done properly, we can see in the image CRL is properly taken and dating has been done, we can attach that report for the double marker.
Right.
Thank you so
Dr.
much.
Bela,
Thank you,
what a
Dr.
Yeah.
beautiful presentation. And as beautiful you dance, I thought it was spellbound as we see your dance.
Thank you.
Very nice.
Thank you so much. Thank you.
Thank you, Dr.
Thank you, Dr.
Bela.
Bela, and best wishes, our
Question I can
wholehearted
ask.
Always best wishes.
Thank you so much.
And congratulations, Dr. Jyoti and Dr. Moni,
Yes.
for the first kickstart of the
Can I ask one
topic of
question,
this
Dr. Bela?
year.
Sure, please. Yeah. Who's that?
I just wanted to know that is there, do you think these genetic causes have been increased nowadays, and is there attributed to life motivation, and can we prevent this increase in the genetic diseases?
So thank you so much for asking that question. There are two aspects to this. Number one, the conditions have not really increased, but we are now able to detect them better with the help of better tests. That is one thing. And second thing, yeah, there is one environmental factor which has added to genetics. That means if somebody is predisposed to a genetic condition and is also exposed to abnormal environment like obesity and so many other conditions we all know, they alter your genes and everything. Yes, it would to some extent affect genetics. But number one, I would say is, as I said, genetics is evolving field. What I didn't know 10 years back, I know today. So because of that, we are able to pick up, suppose the same case of deafness. I wouldn't have been able to pick up before 15 years, Waardenburg syndrome. But because of the test and all, now we have the ability to pick up these conditions and counsel the patient and help them better.
Yeah, especially like age, increasing age of marriage and obesity. These two environmental factors, they are quite important for all these problems also. They make the patient high risk.
So true, so true.
Yeah, thank you so much, Dr. Bela, for that very interactive in an interesting talk, and all the very best. Hope to see you as the Vice President when we call
Thank
you
you, Dr. Jyoti, for
organized
making me
webinar.
part of it. It is you that who invited me. So thank you so much for making me part of this wonderful webinar.
Right. Thank you.
Thank
So moving on now to another interesting, very interesting and practical panel discussion on FGR, early versus late, a tailored approach in the diagnosis, surveillance, and the delivery decisions. So Dr. Moni has done the complete homework for this. I will only take the credit and she has done the hard work. So we have our panelists. I will give over. You can start the screen share, Dr. Moni. And our
so is the screen visible?
Yes. Yeah.
Yes.
Our panelists are Dr. Divya Agarwal, Dr. Gaurav Java, he's a neonatologist, Dr. Savita Singhal, we all know, Professor PGIMS Rohtak, then Dr. Divya Mangla, another professor from NU, Dr. Rachna Gupta, fetal medicine expert from Sonipat. So we have, and our expert today is Dr. Seema Thakur. So we start with our discussion on the FGR. And next slide, please. Dr. Moni, yeah. So over to you. Yes, over to you, Dr. Moni, so that we can start the panel discussion.
Yeah, thank you so much, Dr. Jyoti, and thank you so much for the encouraging word. And you are the true force behind this for always encouraging me to present something related to some practical aspect. And I would like to thank all the panelists for agreeing for this panel discussion, an important panel discussion. So why we are discussing FGR here? Because it is a very common scenario. 10% of the pregnancies are affected with FGR, and it is the second leading cause of perinatal mortality. Birth weight, if it is less than 10 centile, the stillbirth rate is high to an extent of 1.5%. And as the birth weight percentile decreases, the chance of stillbirth does increase. Like if we compare from 5th to 10th centile to less than 3rd centile, the risk is increased by 4 to 7 folds. So this exactly is the etiology of FGR, which can primarily be divided into 4 components: the maternal, placental, umbilical cord, and the fetal causes. The maternal can be anything related causing hypoxemia, anemia, hypertension, and the placental factor which causes placental malperfusion. Then we have the umbilical cord causes and the fetal disorders, which we'll be discussing it in the panel discussion. There are a number of risk factors which attribute to the FGR. So without wasting our time, we'll start with our first case. We have a 34-year-old female She had a bad obstetric history with 1 intrauterine death, 2 spontaneous abortion, and 1 was a late neonatal death. The cause of IUD is not known, but the parents told that the baby was average weight. Thereafter, she had 2 early miscarriages between 7 to 9 weeks, and 1 was a neonatal death at 7 months due to heart disease. The workup was normal. The APLA, the karyotype, and the thrombophilia profile was normal. According to the dating scan, it was corresponding well with the last menstrual period. Level 2 scan was also normal. Because of this bad obstetric history, patient was in echosprin, but at 28 weeks, 3 days, her blood pressure was high. Ultrasound at that time showed all the anthropometric parameters, BPD, head circumference, AC, and femur length less than first centile. And the umbilical artery PI was also high, more than 95th centile. So, Dr. Rachna, are you there? So, what exactly is your diagnosis? Yeah, hi.
Yeah. So this patient, if I'm seeing her first time, obviously I will go more in the depth of her history. The clinical things remain first, and we have to plot her growth on the previous scans on the growth chart. We have to do a detailed anatomy survey, whether there are any abnormalities, even if it per se seems to be very much like a placental insufficiency scenario, but we cannot take it for granted. You have to rule out all fetal causes like chromosomal, structural at least, chromosomal maybe you cannot straight away say, but you look at the biochemistry at least, how was her PAPA or PLGF in the first trimester. If those were low, they will correlate more with the placental insufficiency. And obviously, we need to see whether she's chronic hypertensive or she has just newly developed hypertension. What is the urine albumin, uterine artery Doppler in the previous scans and the current scan? You already said umbilical artery Doppler is high. And so if the scenario is that there was no growth restriction on the previous scans, now the growth has dipped down, there are no structural abnormalities. If that also is we also have the information that there was either a low PAPA or PLGF, uterines are high, then we are more in the favor of uteroplacental insufficiency. Already the growth is below third centile, so there is definitely early onset fetal growth restriction. Now, even if there are no structural abnormalities, we have to keep in mind that early onset FGR can be still due to fetal chromosomal abnormalities or certain genetic associations. So definitely here, the diagnosis is early onset FGR, and now we have to take it forward from there.
Yeah, correctly.
Because
Because first we
less
have to
than 22
confirm
weeks.
dates by the LMP, and
Yeah,
so
that you already
first you have to
said.
confirm the dates that you have already said so, and then confirm the smallness. And next is which growth charts will you use for classifying it as FGR?
So I'm using Hadlock, and this works quite well for me. Like me in the sense that my group of people, like I work at Apollo and Sonipat, and we have been working since 2009, 2008, and all our patients, we use Hadlock to define the growth centile by using BPD, HC, AC, and femur length. So these 4 parameters are used. And this is what we are using currently to define FGR. We are not using other different charts. So to keep it straightforward, keep it very simple,
I think
Hadlock is what
all
we are
of us are, I think Dr. Rachna, most of us are using Headlock only, because in our machines
Yes.
also most of the software is with the Headlock
Exactly.
giving
So
us the.
let's not confuse with any other thing. Let's stick to Hadlock.
Yeah. Does it how much is the difference if you use other growth chart, or mostly, I mean, is there anything different if they, or
If it is
is there a universal
if it is a
reference or something
multiple
like that?
If it is a multiple pregnancy, then the variations come. If it is a single ton, then Hadlock works well. There is not much of a difference. When you come to the severe smallness, like less than third centile, then maybe the other chart may give you fifth centile. But prognosis wise, it will not make much of a difference, because you will anyways have association with Doppler abnormalities. You'll have low amniotic fluid. You will have maternal complications. So prognosis wise, it's not going to make much of a difference. The difference comes only when you have isolated smallness, like Dopplers are normal, there's no maternal complication, you just have a baby which is SGA, then your third centile or fifth centile may make some difference in the management. Otherwise, it's not going to make any difference.
And what about the customized growth charts? Because nowadays they are saying the weight, parity, ethnicity, all these things also needs to be taken into consideration. But I don't think so. The customized growth charts are available and anyone is using that.
No, no.
So now at 29 weeks and 30 weeks, there were the similar findings because the patient was being followed up weekly. But at 31 weeks, the FGR, it was an FGR with an absent umbilical artery Doppler. So absent end diastolic flow in the umbilical artery. So now, how are you going to monitor this case now regarding the monitoring and the
Moni,
surveillance?
you can go back to your previous slide now where you had the absent. I think you have that slide where you, yeah, okay.
Yeah.
So as is very clearly shown in this particular flow chart, when you have absent umbilical artery Doppler, you have to monitor the baby bi-weekly using Doppler. You have to ask the mother to keep a strict chart of the fetal movements. If any time the fetal movements are less, you need to bring her back even before. And there are some guidelines which talk about CTG and that you do bi-weekly CTG and all. But these are more relevant where you don't have the facility for Doppler. If you have the facility for Doppler, then that is more reliable, especially in the context where mother is perceiving good fetal movements. If mother does not perceive good fetal movements, obviously then you need to admit her for monitoring and then do a CTG for at least 40-45 minutes to see whether there are any decelerations or not. So here she will need bi-weekly monitoring. Plus, along with that, remember the maternal monitoring, her blood pressure, CBC, LFT, urine albumin, and also in cases you might need a maternal echocardiography to see that she is not going into any cardiac or pulmonary complications. So all that needs to be taken care of. And I don't know if you want to discuss FLICT1 PLGF, the role of, we also educate.
So that will be discussing later in the predictive indicators. So here I want to ask you another thing. The biophysical profile should be as a universal protocol in all the cases?
So
apart
as
from
I
the
said,
Doppler and the growth scan.
if you have Doppler facility, then it is not required. You have to ask the mother to take care of the fetal movements. That is very important. So maternal perception of fetal movements becomes very important thing here where you have Doppler abnormality already there. Either you admit her and then you do a CTG maybe again alternate day. But if the patient is not ready to get admitted and you have Doppler with umbilical artery absent, then what remains to be is the mother's perception. Then you have to counsel the mother very well that if she is not perceiving fetal movements for 1 to 2 hours, she has to come back and report immediately.
Yeah. So next question is to you, Dr. Savita Singhal ma'am. When to give corticosteroids in these cases? So, and if it is given at 28 weeks, will you repeat the dose?
Thank Dr. Jyoti and Dr. Ragini for giving me the opportunity. Am I audible?
Yeah, yes, ma'am. Yeah.
Can I add on to previous one which was discussed? Like nowadays, we are also not doing this biophysical profile in any of the women. Actually, we're monitoring with the Doppler and fetal movements. Though we are doing the NST in most of the patients, if fetal movements are not okay, then we first go for the NST. Later on, if you question, they will be discussing there also in detail. So role of corticosteroid, definitely there is a role of the corticosteroids. They have to be given for the lung maturation, especially whenever they preterm delivery before 34 weeks. So any patient in whom we are planning to deliver before 34 weeks after the period of viability. So usually which is taken at 26 weeks, I think most of them we are taking at 26 weeks. And after that, impending, then we have to go for the steroid once we think that she might go for the preterm delivery.
And also another thing to note here is that many times
When
when
would
the
you like to
steroids...
repeat?
Sorry?
Yes, yes.
Yeah.
Yeah, the same thing I was asking Dr. Moni, that
Is there
once
need
we've
to
done
repeat?
the, repeat.
Yeah,
when
after-
should
Yeah,
we
repeat.
the
Actually, previously it was said there's no need of to repeat the doses. But yes, sometimes we can do the rescue can be given. That also, once the patient is not delivered earlier or more than 2 to 3 weeks have already passed the previous injection, and again we are thinking that she's going to deliver in next 3 to 4 days, then we can think of giving the rescue to that patient. But it is not like that if the steroid was given at 28 weeks, she didn't deliver till 30, then we keep on repeating. It is not like that. But only rescue can be given in few cases once immediate delivery is there expected after 48 hours.
Yeah.
Can be
And
considered.
another thing to note, yeah, thank you so much, ma'am. Another thing important here is that whenever the patient is being given steroids, there are chances of pseudo-normalization of Doppler, and you may be thinking that the fetus is doing
So
better.
that's why the repeated doses are not
Yeah.
being recommended.
Yes.
Because it has
And,
been thought like, it is my personal observation. Once the patients we are giving the steroids, most of the patients come with a decreased fetal movements. In last 2 to 3 years, we have observed that this thing, and now we are just sure if decreased fetal movements are there after steroid, it is due to the side effect of the steroid. And again, the patient is diabetic. She can have a hyperglycemia. It is not that it's completely free from the things. And once we give the steroids, especially in the IUGR baby, not in the normal, if IUGR baby is there, then the metabolism will be little less, and the hyperdose of the steroid may be more for the baby, leading to some this is one of study, though I am not having my experience, that there may be some developmental problems, cerebral, this ischemia might be there.
Yes,
But not
steroids.
Yeah.
Can I
Yeah.
can I just add my
I
experience?
want
not
to
the proven one thing. So yes, Dr.
So-
Rachana.
So, ma'am, steroids are always double-edged sword. And especially in the diabetic, we have had at least one patient who was given steroids at 32 weeks and the movements were reduced. She thought it's because of steroids. And within 48 hours, she came with an IUD. So,
Yeah, that's why I'm saying that. So decreased fetal
Very-
movement, very, very common. We are observing a decrease, it is due to steroid.
yeah, but then they have to understand that it's not just that you have to ignore those reduced fetal movements still.
Yeah, another thing I want to add here, the ACOG in the FIGO guidelines states that normally we say the next dose should not be repeated, and if the delivery is planned in the next 7 days, one dose is sufficient. But sometimes if the delivery is delayed more than 14 days, then the second dose can be repeated. And the study also says, the MFMU study said that repeat course of corticosteroids have a more chance of developmental delay and cerebral palsy when 4 doses are given. As far as the preterm rupture of membranes is concerned, in those cases, we say that the repeat dose of corticosteroids should not be given, but ideally we should plan the corticosteroids accordingly whenever you have the imminent delivery in the next 7 days.
Yeah, second dose will be given only if she's definitely going to deliver. Like you have passed 14 days and now she's definitely going to deliver like after 48 hours. Because you again, here the role of neonatologist is also important. I think we can also ask Dr. Gaurav what is his take on this. Because neonatologist also has to give their opinion, what they think about the repeated doses of steroids.
Hi, so good afternoon, everyone. Thanks for this question. But what we usually recommend is, as per your guidelines, this is the FIGO guidelines, but I think the AAP and the Australian guidelines say then a second course can be repeated if the delivery is imminent in the next few days, less than 34 weeks. I mean, a gap of at least 2 weeks, and still the deliveries should be happening less than 34 weeks. In these cases, the incidence won't increase for cerebral palsy. It's when the delivery continues beyond 34 weeks. I mean, you failed to recognize that the delivery was not going to happen immediately, and this pregnancy continued beyond 34 weeks. Those cases, yes, multiple courses of steroids might lead to slightly increased incidence.
So, if we are giving second dose of steroids, you will again repeat the full course.
Mostly the talk is about course and not a single dose.
Yeah.
So when you're doing, it's the second course. Yeah, if you don't have time, you can give a single dose, but mostly they're talking about a second course of steroids.
Exactly.
So you repeat the again course if it is more than a week and there's
More than
imminent
2 weeks.
More than 2 weeks, not
More than
weeks.
2
More
weeks.
than
Can
2
repeat
weeks.
the course?
And impending delivery should be there. You're
2 weeks.
definite that delivery is going
Yeah,
to
next
happen.
time
Otherwise,
impending
don't need to
delivery should be
do
there.
this.
Less than 34 weeks, correct.
Yeah, less than 34 weeks.
Right.
And sometimes no
So,
time is not there. Even single dose is effective. You're not having the time for the 48 hours is not there.
Yes.
Our
It is better to give even
neonatologists
a
are
single
we are
dose.
following this in our institute. If proper time is not there, even the few doses, maybe 1 or 2 doses will also have some effect on the
So,
maturity.
Dr. Gaurav, does giving steroid between 34 to 37 weeks have also any role? Because few of the articles I read, it was mentioned there that the corticosteroids may be considered. It was not recommended, but it was mentioned that it also decreases the chance of RDS.
Yes, yes, there are. I mean, the may word is still being including in a lot of, guidelines. But as a rule, with so much of data now collated, so many of reviews, so many of meta-analysis, that the late preterms will never benefit so much so as the harm that's going to happen. So all of these kids did end up having some neurodevelopmental problems, some kidney problems also. They ended up having lesser number of neurons and nephrons both when the delivery continued beyond 34 weeks, or when you selectively gave steroids for 34 to 37 weeks. The only small subset that might benefit is the diabetics. The rest of them, they will not benefit at all. The slight increase in the RDS, I mean the TTN primarily between 34 to 37 can be avoided by giving steroids. But in other cases, you will harm the pregnancy by reducing the number of nephrons and neurons for sure.
Okay, so
Thank
it
you
is
so much.
advisable not to give after 34. That means
Correct.
this
Late
will
preterms will
be
not
the
benefit
method.
at all.
Right. So now, how would we, Dr. Divya, how would we decide the time and the mode of delivery in this particular case? We've given her steroids. She's around 31 weeks now, and we wish to deliver her. So, what would be the mode of delivery in this case?
So, yeah, good evening. Thank you so much, ma'am, for giving the opportunity. So, as we are talking about this case is a case of stage 2 FGR actually at 31 weeks of pregnancy with hypertension. That is 160 by 100 millimeters of mercury that was told. So, she's having absent end diastolic flow in the umbilical artery. So, looking at all the features, so first of all, I would like to, one thing is at 31 weeks when she has received corticosteroids, I don't think we really need to deliver her. If the Doppler studies are showing the same result, that is umbilical artery showing absent end diastolic flow, the pregnancy can very well be continued till 34 weeks, of course, with a proper maternal and the fetal surveillance. So maternal surveillance will be in the form of looking for all the basic, all the routine investigations, including ruling out her anemia and all. And second is we have to be worried about her blood pressure, whether it is well controlled or not, or she's developing any severe features of preeclampsia or any complications with that. Accordingly, we will have to decide. Second is the Doppler studies. If she's moving towards, say, for example, stage 3 FGR, the Dopplers are worsening, then we have to think of. Otherwise, we can continue the pregnancy as per guidelines to 34 weeks of pregnancy, and the mode of delivery will be by cesarean section in this case.
Yeah. So after 5 days, a repeat Doppler showed a reversal of the end diastolic flow in the umbilical artery, and the DV PI was more than 95th centile. So do you think is the time to deliver her now?
Yes, absolutely. Now she has become 31 weeks, 5 days, and reversal of reverse end diastolic flow in umbilical artery. So, now she has moved to stage 3 FGR actually. So in stage 3 FGR, it is recommended that we need intensive monitoring every alternate day. And because she is now 31 weeks, 5 days, so we have to deliver her by say 32 weeks. So again, the mode of delivery is going to be cesarean section. And in this case, now we should deliver her because the chances of having the stillbirth are very high in cases of reversal that goes up to 19%. Whereas in absent end diastolic flow, the chances of stillbirth are around 6 to 7%. So here we have to do the proper counseling and terminate her.
Yeah, so once there is a reversal, we don't have much time. We have,
Yes.
I mean, 2 days is the maximum within two. So once there's absent diastolic flow, the 5 days is the maximum target, and with the
Yes.
reversal, we have only 2 days,
2 days
in hand where we need to maybe give her steroids, deliver think of the mode of delivery, the place of delivery, get the team ready, get the NICU people ready, and Dr. Savita, ma'am, how would you?
Yeah, actually, if a reversal is there, we have to go for the ductus venosus as well.
Ma'am, that was given.
Yeah, because sometimes we can with reversal also, sometimes we can see we can continue pregnancy for 1 week, but it has to be combined with the ductus venosus. But ductus venosus is the final thing where the if reversal is there or absent flow is there, then we have to terminate immediately within 24 hours. So we have to combine with that. Sometimes because we will going further in the management, if reversal is there, then go for this and we can wait for 2 to 3 more days with the reversal. Now in this patient as already Divya has brought out very rightly, now patient needs the termination because she is around 32 weeks and ductus venosus is also affected. And we have to counsel the patient that if you continue, then also some chances of stillbirth are there. Not chances of stillbirth are definitely there. We are continuing more than 48 hours or maybe 2 to 3 days. And another way, the counseling regarding the prematurity, if you deliver, if we don't deliver, then chances of stillbirth. If we deliver, chances of IUGR baby and prematurity are very much there. So chances of this stillbirth are about in patient who is well managed, being in the hospital, 1 to 2% chances of stillbirth are there in the well monitored patient. And then regarding the risks of the prematurity and IUGR baby. In the prematurity baby, there are the risk of, like we say that this metabolic disorder, metabolic changes are there, hypocalcemia, hyponatremia, hypoglycemia, and then neonatal complaint, the neurodevelopmental problems can be there in the baby, especially in all IUGR babies, usually 2 to 3% neurodevelopmental abnormalities can be there, hypothermia. So these are the all complete respiratory distress. First one is the patient can be distressed. Later on, there can be cerebral palsy. So these are the complications like interventricular hemorrhage, neonate this encephalopathies in the baby. So these are the problems which can occur in this baby. So after this proper counseling, we have to deliver the baby. It is not that the patient क्या पूछता है usually कि आप cesarean कर रहे हैं तो बच्चा पूरा ठीक है, बिल्कुल ठीक हो जाएगा. So we have to tell the in both ways that there can be these problems with the baby after delivery, and proper counseling pregnancy has to be terminated.
Yeah, very
Yeah, so
important
as this slide very nicely, Dr. Moni has put this slide. As the gestation age increases, our risk decreases. But we still have to weigh and balance between the stillbirth, as Dr. Savita was saying, and between the prematurity, IUGR, and the other risks. But with each passing week, our neonatal survival increases. So if we have crossed 30 weeks, there is more than 90% neonatal survival. And if we are less than 30, there are 35% chance of major neonatal complications, whereas if we reach 34, it becomes less than 10%. Now,
but one very, very important thing about the survival is the type of nursery. Once you're planning to deliver these babies with IUGR and prematurity, the nursery should be very good. Only these survival rates, 90% are for the best of the nurseries. If nursery is not good, it is better to transfer the patient in utero to a better nursery where they can deliver.
Exactly. Yeah. So one should know the limitations of the nursery, how good your nursery is, and the expected fetal weight, how much with that, what is the prognosis. Yeah. So all this should be discussed with the pediatric neonatologist and the patient and the obstetrician should all sort of talk about it and then decide the time of termination and the place of termination. So this baby was delivered by CS, birth weight was 1100 grams with the APGAR of 6 and 9. And according to the neonatologist, the baby is doing well. So I think now we come on to Dr. Gaurav. Dr. Gaurav, what would be the early neuroprotective strategy that we can do in IUGR babies? And what are the other metabolic risks, the complications that are there in these FGR cases?
Right. So, I mean, for the neuroprotective strategies, they start right from your ball game. And antenatally, corticosteroids for less than 34 weeks do protect these babies against clearly known IVH and PVL. I mean, everybody knows about them. We don't need to reiterate it. But magnesium sulfate has a significantly reduces the risk of cerebral palsy and substantial gross motor function risk is also lower by magnesium sulfate. It has time and again proven to be of very good use as a neuroprotective strategy itself. The newer things that are coming up and still experimental although now human experiments are also going on in the West, is melatonin. It acts as an antioxidant, neutralizing a number of radical oxygen species and reducing the damage that intrauterine growth restriction itself is causing to these infants. Preliminary results indicate that it has a very good role to play to reduce the placental oxidative stress in pregnancies complicated by FGR. Then N-acetylcysteine, DHA, AR in the mother as well as postnatally. Our biggest strategy to prevent the long-term neuro damage to these child is to prevent IUGR, a big concept that's coming up now after a lot of IUGR babies getting the survival nod and getting delivered nowadays, is the extra uterine growth restriction. So there is a very clear correlate between the nutrition that's provided to these infants. We have to balance them out quite well. The biggest correlation factor is the NICU stays head circumference increase till the child gets discharged and long-term neurodevelopmental disabilities. So if the head circumference rise was approximately 0.5 to 0.7 centimeters every week for these infants, and they grew quite well, they did not fall down the centiles they were born. In fact, they started to rise up beyond the third or 10th centile through the NICU stay. If they got good nutrition, good protein, then these infants tend to have the best long-term neurodevelopmental capabilities as compared to the other infants.
So this is regarding the Maxel, when it should be given, how much dose should be given. It should be given till 30 weeks or till 34 weeks.
So every guideline is different. AAP states till 30 weeks. I think RCOG states till 32 weeks. The Australian guidelines say till 34 weeks. In India, as far as I know, everybody practices till 32 weeks. So we also in our Apollo follow up to 32 weeks. Every impending delivery, which might deliver within 24 hours, we load the mother over half an hour with 4 grams in 50 ml of magnesium sulfate. Then we continue every hour at least for 6 to 12 hours till the delivery is impending. We don't stop our next proceedings. For magnesium sulfate to complete, we just go ahead and start infusing 1 gram every hour.
So what about the metabolic? Yeah.
Yes, so metabolic risks, there are early metabolic risks, and something that we are talking about more now about IUGR infants is the late metabolic risk. The early metabolic risk, everybody is very well aware of. They don't have any stores of their own. They hardly have any fat reserves that they can burn out. So immediate to within 24 hours, hypoglycemia is a big risk factors. We keep on monitoring them 2 hours, 6 hours, 9 hours, 12 hours, 24 hours. For the first at least 24 to 48 hours, we make sure that the sugars are maintained above 50. Then hypocalcemia, hypomagnesemia, polycythemia leading to jaundice or even other disturbances are very common. Initial metabolic risks. We all tend to manage them easily, but it's the late ones, that fetal origin of adult disorders, the metabolic programming that affects these infants is the one that we are really worried about. That excessive postnatal nutrition can and a subsequent sedentary lifestyle increases the risk for metabolic syndromes, insulin resistance, and cardiovascular diseases. Their lack of satiety due to derangement of their hypothalamic orexigenic or anorexigenic neuropeptides. There have been a lot of reports and a lot of meta-analysis that tells us that insulin resistance is very common in these IUGR, long-standing early FGR infants, and it hits as early as 1 year of age. And if we tend to increase their centiles very rapidly, if they have crossed 2 centiles in their growth charts, their chances of ending up obese, overweight, and a lot of problems, especially in girls with PCODs, is going to be very high due to established insulin resistance. IUGRs can also have abnormal concentration of circulating insulins, catecholamines, growth hormones, and insulin-like growth factors. And there is a lot of visceral adipose tissue that's highly increased in IUGR fetuses because of the overall fat mass reduction. So these babies tend to have a very misbalanced, imbalanced problems that can happen later on in life, not just acutely, but later on. These babies tend to do very better from a respiratory and cardiac point of view, but quite bad from a metabolic point of view, early as well as late. So So these are again the neural complications that are anticipated in the early FGRs. Prematurity is a big deal for early FGRs. They do end up most of the times to many times getting delivered premature. So we have to deal with their prematurity complications. There are a lot of studies that state that IUGR alone versus IUGR plus premature, it's going to have a slightly poorer prognosis as compared to IUGR alone. Then pulmonary hypertension is a significant problem other than respiratory distress syndrome. These babies tend to have slightly improved maturity of lungs because of the constant secretion of catecholamines under stress. But pulmonary hypertension can be a big phenomenon in these infants. Then, of course, hypothermia. And I've already listed the metabolic problems that happens. Then recently we had an early FGR delivered at 31 and 3 weeks, very similar to your case. The child was started on feeds, 1300 grams, and within 24 hours had a perforation. And we had to deal with the perforation over the next 7 to 10 days actually. So NEC is a big problem that happens in early FGRs. Prematures tend to have a late NEC chances, but early FGRs tend to have within the first few days of NEC risk. Then of course the immune systems are quite deranged. Long-term problems I have already listed, that poor physical growth. We always tend to struggle in these infants with bringing them up to their sizes. The parents are always constantly cribbing about these children are not looking up to the size of their colleagues. Then neurodevelopmental impairments, we'll mention it later, that are a big issue nowadays that is being considered. Cardiovascular diseases, metabolic syndromes, and the decreased number of nephrons can result in hypertension in these infants. And visual and hearing defects are also known, primarily also because they are born premature, but also IUGR itself causes issues with this their vision and hearing.
Thank you so much. So, Dr. Divya, how will you counsel her for future pregnancy based on the current scenario that it was a case of early onset IUGR with placental insufficiency?
So thank you very much, first of all, to the team of ISPAT for giving us this opportunity here. Now, this is a case of early onset IUGR in the setting of, I would also say, a previous IUD, previous spontaneous abortions in this female. And early, so, we must not say that, the cause is definitively placental or maternal. It could still be fetal. I mean, I would say that, it could still be a fetal cause which led to the growth restriction because it was early onset. And then we are getting some bad obstetric history, which could occur either with maternal or uteroplacental causes also, but even more in the fetal causes, if there is a fetal recurrent cause that this couple is dealing with. Now, here comes the importance of we do not have any genetic tests yet on this fetus. However, how this fetus behaves, how this baby behaves now in an extrauterine form, we will need to sort of monitor the baby. A geneticist or a neonatologist with some dysmorphism bent of mind needs to look at the child. A thorough examination of the child is needed to sort of, see whether it could still be some inherent fetal cause which led to the growth restriction. We needed to examine the placenta, which would have been done to sort of, see whether it was uteroplacental insufficiency, a histopathological diagnosis. All these things may not lead us to the etiological diagnosis for sure, but they add up, they add up to making the diagnosis, which is relevant then to counsel the couple for the next pregnancy, because we need to get to the etiological diagnosis as far as possible accurately. So, if it was a fetal, if it is in fact a fetal genetic cause, then we need to do the testing for the baby and then see whether there could be a recurrent cause. However, I'm presuming that, we have all, this is uteroplacental insufficiency, which has led to the growth restriction. If we are presuming that, then the risk of recurrence remains low. However, it's not zero, because now we know that there are genetic factors involved even with the uteroplacental insufficiency as well as the maternal factors. So all these, Dr. Bela Bhatt talked about something known as a multifactorial causation, which means genetic factors working in along with the environmental factors. So we see that even when the cause has been maternal, there is an increased risk of recurrence every time this lady becomes pregnant. And there could be some genetic predisposition along with some environmental factors like obesity or some other factors, which add up to this lady being at increased risk every time. So there is an increased risk of recurrence, even when, because of this growth restriction was because of uteroplacental insufficiency or because of maternal factors, as compared to a woman who has had no history of any
So
IUDs or
how do we counsel this lady, Dr. Divya?
So, we would need to counsel her that there is an increased risk of recurrence, as Dr. Moni has mentioned on the slide. And once we are sure that, this is not an inherent fetal cause, this is a uteroplacental or a maternal cause, we need to counsel her that, see, there is an increased risk of recurrence next time. There could be some genetic predisposition, which we cannot really control for you. So we need to control the environmental factors, we need to control the anemia if there is any, we need to control any of the other factors. That's all that we can do. These
So we have to ask her to. Yeah, the other things that we can start with the ecosprin for her. She was a case of PIH, so she has to, that way maybe we can do early the first trimester uterine artery Dopplers and all early in the next pregnancy, which and start aspirin in such cases. Give her, if those smoking, obesity, her diet, if weight, if extremes of weight and all those things are there, I think
these
we
are
can
empiric supportive strategies that we need to do.
So, Dr. Divya, what exactly is the role of PLGF and SFLT in these cases of early onset IUGM?
So,
for the screening purpose.
Yeah, so I think Dr. Rachna can go ahead and, say more about this. But because, at Apollo here, we do use PLGF screening and, she can elaborate because we do this screening for all such women. So Dr. Rachna, if you could just elaborate on that.
So basically, we use FLT1 PLGF ratio, and mainly it is for the women who don't want to get admitted, and we are worried that they are at high risk of developing preeclampsia related complications. If the FLT1 PLGF ratio is within the normal limit, like it is less than 35, we are very confident that she can come back in a week's time, and we can monitor her on an outpatient basis. Whereas the ones who have a high ratio, FLT1 is high, PLGF is low, then these women, we tend to call them either alternate day, twice weekly. We tell them to do CTG locally or get admitted. They are at much higher risk of ending up with preeclampsia related complications in the coming week, 1 or 2 weeks. So that is how a low value just tends to tell us, okay, she is not going to end up into drastic complications within a week or so. That is how it helps.
So, Dr. Seema, AC or expected fetal weight or both centiles for IUGR, which is a better one?
Dr. Seema we come on to our expertise. Is Dr. Seema there?
She hasn't joined. I cannot see.
Dr. Seema is not there. Okay. So, Dr. Rachna, you can tell us about what would be better, AC or EFW?
Usually they go hand in hand. It's not that you will have.
Dr. Rachna?
Yeah.
I think you can take it up.
Can you hear me?
Yes, yes.
Okay. So I'm saying most of the times they go hand in hand. If you have a AC which is small, you will also have majority of the times estimated fetal weight also being on the lower side, if not less than third centile. So it's always good to take into account the whole of the picture. Yes, if you have only AC affected and your estimated fetal weight is still more than 10 centile, those babies tend to do better compared to the ones where you have estimated fetal weight less than third centile. But anyways, you cannot ignore even if the only AC is affected and EFW is not affected. Those babies will also need monitoring the way we are monitoring the ones with EFW less than third. It's all about like the chances of ending up with complications is less the ones where the EFW is spared.
Yeah, as rightly said, it goes hand in hand. But if we compare, this was just an article from AGOG, where they have compared whether expected fetal weight or AC is associated with worse outcome. So they found that the neonatal weight, the APGAR score, the NICU admission was worse with expected fetal weight as compared from the AC. But yes, as rightly said, according to the definition, we go hand, both the AC and the expected fetal weight are taken into consideration whenever we are classifying it as FGR. So there are two classifications which are being followed, the Society of Maternal Fetal Medicine and ISUOG, because we have been mentioning about this ISUOG classification, that the fetal weight, the solitary parameter or the combined parameters. The Society of Fetal Medicine says that if the expected fetal weight or AC is less than 10 centile, we classify it as fetal growth restriction. So how do you define that? Which is a better one?
We go by SOG.
Okay, because the ISPAT is more stringent and has a better specificity as compared from the SFM classification.
Much more reviewed, much more researched, and always validated. If the Barcelona, ISWOG, FMF, all these three are almost same, COG, all four are almost similar. So I think this is what we should stick to.
Yeah, coming on to the next case, this case I'll keep it short because normally we define an FGR without any abnormality, but this is a case with some congenital malformation, so I'll keep it little short. This was a case of 39-year-old female. She was corresponding by dates and LMP as 23 weeks 1 day, but in the level 2 scan, it was IUGR. All the parameters were less than third centile. Apart from that, there were abnormality in the ultrasound in the form of corpus callosum agenesis with a mild ventriculomegaly, and the double marker was normal, and the NT-NB scan was also normal. The PAPA was low in this case. So these are the parameters, the BPD, HC, and AC. All the parameters, as you can see, are on the lower side, and there is colpocephaly, agenesis of corpus callosum. So, Dr. Divya, what is the significance of corpus callosum agenesis with mild ventriculomegaly in early onset IUGR?
So, the presence of any malformation, as you said, it increases the suspicion of a genetic condition and an inherent fetal cause, which is leading to the smallness and a decreased growth potential of the fetus. The presence of a malformation as well as the setting in of severe growth restriction as early as detected at the level 2 scan increases our chances that this is indeed a genetic cause leading to the fetal smallness is much higher. Our suspicion is much higher, and hence the fetal testing needs to be done. The risk, the corpus callosum is a midline structure, and the corpus callosum malformation can be associated, either it could be an isolated malformation or mostly it could be a subtle sign of an inherent cortical malformation, which can occur due to the fetal genetic problems like chromosomal abnormalities, or there could be single gene abnormalities, which are listed. Some of them you have listed here on the slide, and hence, it increases, it should prompt the testing of the fetus for these conditions.
So now in this case, we would order amniocentesis in this case to identify the cause. First of all, the counseling is very important regarding the prognosis of this fetus, because the fetus is having agenesis of corpus callosum with fetal growth restriction. So what about the prognosis of this fetus? How will you counsel her regarding the neurodevelopmental outcome in this case?
in the presence of, if we are able to diagnose a genetic condition, then according to the particular syndrome that we diagnose, we can give the prognosis. However, if we are not getting to a definitive genetic diagnosis, either we haven't done the testing or the patient refused testing, or we do not get a diagnosis after the testing, an empiric counseling needs to be done, which means that, based on the literature, it is known that more than 50% of these children will have some neurodevelopmental delays. However, 30 to 50%, there are varied number of studies and varied figures, but 30 to 50% of these fetuses with agenesis of corpus callosum might have a neurodevelopmental, might not have neurodevelopmental delays. So, then we'll have to really do an empiric counseling if we do not reach to a definitive diagnosis.
Dr. Divya Mangla, the patient has refused amniocentesis. Now, anyways, our aim is to reach to the diagnosis to help the family for the next time. How will you counsel the patient for the need of fetal autopsy in this case?
Yes, absolutely. This is going to be a very difficult situation for an obstetrician, actually. She's already reaching to 23 weeks plus and by dating scan as well as her LMP, and refuses amniocentesis. And we are not at a specific diagnosis. So first of all, for fetal autopsy, we have to tell that fetal autopsy can help them to actually diagnose the anomaly which is there and what is the exact diagnosis due to which it is there. And we have the tissue available for the genetic testing. The genetic testing can be done, all the chromosomal and all the genetic testing, as well as we get the placenta also, so that it can be sent for the histopathology, and that can also help us to know various placental conditions. Moreover, they can be counseled that once we do all the fetal autopsy and we get the genetic testing done, we can very well help them to prevent the recurrence in the next pregnancy. And a proper way of monitoring the next pregnancy, maybe because with the help of CVS or something, that can be done so that the outcome in the next pregnancy can be very well given. So that way it can help them. And regarding the ethical and the clinical responsibilities, which you have, the question is being mentioned, because as I said, we are already nearing 24 weeks. And as per the law of Medical Termination of Pregnancy Act only allows us till 24 weeks. And we are still not at a particular diagnosis. So it is a very tricky situation, and all the obstetricians actually, first of all, we have to keep the MTP Act in mind, and considering the gestational age, 2 obstetricians will be required, and it is better because as per the indications which are given in MTP Act, so this case may not fit into those that indication of gross fetal anomaly which is incompatible with life. So we may have to take the help of the legal experts in that, whether we should go for MTP in these cases or not. And second most important thing, whatever we do, we have to do it with a proper consent, and of course maintaining a proper documentation in such cases, which will be very, very important. So we have to balance, because it is very risky for us as obstetrician also. That's what my point
as you
is.
rightly said, the placental histopathology is also very important. As Dr. Divya has also mentioned it in the previous case, that placental histopathology also helps us to know the risk of recurrence in the future pregnancy. Like there are few conditions which may have a risk of recurrence up to 40 to 60%, like the massive perivillous fibrin deposition, where you can try giving IVIG or aspirin heparin in the next pregnancy. Or it can be 70% if it is due to chronic histiocytic intervillositis. So placental histopathology is very, very important as a part of fetal autopsy. And also if there is early IUGR and after delivery also, the placental histopathology should also be offered in all the cases. So now these are the pictures of the fetus. There was middle gap, there was clinodactyly, the mongoloid slant, and so these findings were going in favor of trisomy 21, and it was confirmed by the QF-PCR. So now, Dr. Gaurav, what would be the postnatal care plan in Down syndrome or in the Down syndrome with agenesis of corpus callosum with FGR?
So it is very unusual for trisomy 21 to present with, brain malformations. But as and when the trisomy 21 gets to get delivered, I mean, as you can see by the table that we always go ahead with cardiac evaluation. We do expect feeding issues and some hearing issues, but we don't expect trisomy 21s to get delivered premature, as in against a case of trisomy 21 with IUGR or FGR per se. Then immediate metabolics are not at risk so much when we establish feeds in trisomy 21. Then respiratory and lung issues because the child is FGR and because the child is, the other malformations also are higher in such a child when combined with a malformation. Then NEC, ROP, and a long-term neural development point of view. Uh, each of these individual issues, a trisomy 21, absent corpus callosum, and FGR itself, individually, they're all associated with some neurodevelopmental problems. Combined, all three will have a very moderate to severe form of neurodevelopmental problems for sure. I mean, it gives the child a long-term neurodevelopmental outcomes quite poorer to quite worse condition. Whereas, trisomy 21 can have a mild to severe, depending on the severity and the genes, a mild to severe kind of a outcome. So therefore, in trisomy 21 plus ACC plus FGR child, we would be preparing more for complications, immediate respiratory and metabolic, as well as for a poorer long-term outcomes for sure. So developmental outcome in a absent corpus callosum, the data that's been collated since 1995 till date. I mean, a lot of systematic reviews have shown that just an isolated corpus callosum agenesis, whether it is partial hypoplastic or a complete corpus callosum agenesis, it has to be isolated, meaning you've ruled out the genetic problems and no other associated malformations, would result in almost 2/3 to almost 60% around. Most of the data suggests 60% of these children doing quite well. So long-term outcomes neurodevelopmentally are quite nice. So 60% of these infants will have a normal long-term neurodevelopmental outcomes to slightly mild neurodevelopmental delays. Around 25%, 20 to 25% of these will have moderate neurodevelopmental disabilities. And the fact that we must tell these parents is that approximately 10% of these infants can have ending up severe neurodevelopmental disabilities. So yeah, 60 to 65% is a good number to quote. But the minute you quote them, 10% will have severe neurodevelopmental disabilities. That's where the stress starts to bear, because I mean, it's very difficult to point out which child is in that 10%, which child is the 60% of these cases.
I think the last Dr. Gaurav was also was taking now. Should the we were on the third this question, the genetic testing. Should we do genetic testing for all cases of early onset IUGR? Dr. Rachna, what is your take on this? So that this is the final question, and then we wind up with the discussion for today.
We definitely discuss invasive testing with all cases of early onset IUGR, and that tests for chromosomal and genetic abnormalities as well as fetal infections. So here we have written that, okay, if there's a malformation, polyhydramnios, there are additional risk factors. They increase the chances of diagnostic yield. But even if these findings are not associated, you don't have structural abnormality or polyhydramnios, we discuss as the research, the literature says that there is about 20% chance that you find something on the genetic evaluation. So yes, we offer, but it's up to the patient to take it up or not. We counsel with all the risks associated, the prematurity, the chances of prom, so all those risks are counseled, and it depends on the patient whether they take it up or not.
Right. So it is a good idea to at least inform the patients, inform the couple that this is something which can help us in making a diagnosis, in helping, in counseling them, and also maybe in their future pregnancy, maybe we can take help from what the finding are of this particular genetic test in this particular index pregnancy. So I think
sometimes it is also helpful in the management of the current pregnancy. Suppose you have a chromosomal abnormality, then thinking of delivering her by C-section, the timing of delivery, the place of delivery. So if you have a positive finding, then everything needs discussion. And suppose it's an infection, for example, cytomegalovirus, then you're going to offer treatment. And again, the neonatal management accordingly will vary with the diagnosis. Dr. Divya Agrawal can also add to it.
Yeah, and I also thought that, we've had a few cases wherein reaching to a definitive diagnosis have helped us counsel the family continue the pregnancy, because some of these genetic conditions we know that that they will have a good outcome, they will have a normal neurological outcome in an isolated IUGR, and some parents might be very much okay with having a child who's slightly smaller and having a normal developmental outcome. So it also just reaching to a genetic diagnosis does not mean that this means that they're going to be terminating the pregnancy. It has helped us in counseling the families to continue the pregnancies also.
Very right, very true. So, I mean, it is not just the end, genetic testing, it is just the termination. It is not the end of the story, but it has, I mean, a lot can be done intrapartum as well. A lot of therapies can be taken, especially for infections. And definitely, it can help us guide the pregnancy as well. So, Dr. Moni, your comments. And finally, I think this is, we are nearing 1 hour, more than an hour with the panel. So we can, I think, stop it after your comments.
Yeah, next time we'll discuss the late onset FGR as well. So also regarding this RG-Preg, many times the RG-Preg supplements, the lycopene, these supplements do not have any role.
Only we are not discussing the late onset today.
No, ma'am, we are getting late. The next time we'll plan next time the late onset IUGR. So basically the supplements, whatever are being given, like the lycopene, RG-Preg supplements, many times low molecular weight heparin is also being given in these cases. It does not have any role in these cases of FGR. So it is not recommended at all. So Dr. Jyoti?
Sorry, I couldn't hear you, Dr. Moni. Sorry, I missed you.
So basically, my main concern is many times the obstetricians are advising the nutritional supplement to improve the growth of these babies. The important point is the monitoring and the surveillance, which is important. First, reaching to the diagnosis, monitoring and surveillance is very important in these cases. The supplements do not have any role in these cases. So it is not going to improve the growth in such cases. So these are not recommended at all. So wanted to
these
discuss
IV hormone and all that the IV hormone that we give or argin or even we give vasodilators to improve the placental flow, and so they are not of much help. They are more of like placebos. Dr. Rachna, what do you say about it? About the role of
I think they do more harm. They do more harm than any good to the patient. So many patients. I remember we had a patient with high uterine artery PI reported in 24 weeks, and the obstetrician started her on low molecular weight heparin. She ended up with an abruptio at 28 weeks. So, I mean, these are therapies which are actually going to be more harmful, especially the vasodilators, the sildenafil. These are very harmful for the patient herself, and they increase the chances of adverse outcomes rather than causing any benefit, giving any benefit to the pregnant patient or the fetus. So we must avoid all these things and just stick to the things like, which are proven to be beneficial.
Dr. Neeta is asking, can we give aspirin?
So again, no role beyond 16 weeks. So again, it has some side effects like 3 in 1,000, we say it can cause GI bleed. So after 16 weeks, the benefit is lost and it is not, again, no value added to the management of the pregnancy. Better to tell her about the diet, high protein diet, make sure that she's taking good diet, having a good lifestyle. Those things will make more difference. And then proper follow up. They should come for the scan regularly to see how the baby is growing, putting on weight or not. So I think lifestyle management has more role than aspirin after 16 weeks, and BP monitoring, picking up the complications early, acting upon the complications if she's developing hypertension, then starting antihypertensive at the correct time. Those things are more relevant.
Right. So maybe lifestyle changes, avoiding smoking, tobacco, or use of all these drugs, and those things, if they can be taken care of. If she's a cigarette smoker, absolutely. I mean, if one can cut down on that or go on to e-cigarettes or the tobacco patch or something that I was reading. I mean,
Cigarette, probably she will stop herself. The problem is we don't really emphasize much on the proper diet. People hardly ever like to go to a nutritionist. And that is the one most important aspect of management of these pregnancies, whether they are diabetic or hypertensive, obese, or having growth restriction. A good meal plan is something which helps a lot, and this is often overlooked.
Okay. So we take care of diet only in diabetics, but I think this is another aspect that we should also think of and should also start, I mean, putting it in our practices, that for FGR cases, the maternal nutrition is also something we should focus on. And definitely, apart from taking care of the medical complications, which could be the reason of fetal growth retardation, and a good surveillance is something, right from the first trimester scan onwards to the growth scans to the Dopplers, that we should at least start at 32 weeks, a good surveillance for all our pregnancies. So the late onset IUGR also can be picked up. I mean, early onset definitely we can pick up in the till the mid trim, till the level 2 scans we can catch them and start the we can take due steps to rectify, control it, and to plan the pregnancies. And the other, I think the mode of that we have already discussed in detail about how frequently we do the monitorings, the fetal surveillance, the CTGs, the fetal kick counts. So these are important things, and we should be in rapport with the radiologist or the sonologist or the fetal medicine expert who is doing the Dopplers for such cases. So and not to forget the neonatologist who will be catching hands with us for such a difficult pregnancy. So thank you each one. Thank you our panelists, Dr. Divya Agarwal, Dr. Divya Mangla, Dr. Rachna Gupta, Dr. Savita Singhal, and Dr. Gaurav. It was, I mean, you were very rightly chosen for this panel, because you all had not only knowledge but also a lot of practical insights about the topic. And so we missed having Dr.
We missed the late onset, which is more common
We will,
than
we will
I
discuss
think
that
we should
also.
have another webinar on that, no?
Yeah, we will. I think Dr. Moni will. This is part 2. Then we'll have on FGRs. So,
That's
and
good.
also we are thanking my speaker, Dr. Bela, who was brilliant, and also the chairpersons, Dr. Neeru, Dr. Meenakshi, and Dr. Rakhee, who made it so very interactive. And thank you, Nimisha, Jagsonpal. Thank you all the delegates who were there. And thank you, Haryana ISPAT. Let's have the flag high, and let's gear up so that we do not have any baby which has any problem, any malformation, any anomaly, any retardation. I mean, we have so many things that have come up over this particular decade, and I think we should utilize this to help our patients and to have a healthy baby. So that is ultimately should be our goal of each and every obstetrician that is there. So thank you, each one. Thank you for me. Thank you so much.
Bye.
Thank you, Nimisha. Thank you.
Thank you. Thank you so much.
Thank
Bye.
you. Bye-bye. Thank you, Dr. Moni. Your panel was absolutely wonderful. She only made the complete panel.
Very well prepared, very
She's
nicely.
done
She
a
did
very hard work.
lots of hard work for preparing the.
Yeah.
Very nice panel, Dr. Moni and Dr. Jyoti, Dr. Savita. Hi. So we'll be waiting for another one where you'll take
Yes,
late onset IUGR, no?
Right.
Okay, bye.
Okay,
All right.
bye.
Bye.
So thank you everyone for joining in today. The session was today brought to you by Jagsonpal Pharma, the makers of Endurect, Devatron and Injection Maintain. Thank you, and we look forward to your participation in the next webinar.